Welcome back to Decode Healthcare with Harshel. It's time for part 73 of our ICD-10-CM official guidelines series. Today, we are diving headfirst into Chapter 6, unpacking the highly specific and, let's be honest, sometimes completely baffling world of the nervous system. Our mission in this explainer is to decode some of the absolute strictest coding laws CMS has thrown at us. We're going to tackle epilepsy and tractability, map out how to distinguish primary Parkinson's disease from secondary Parkinsonism, and lay down the law on Category G89 pain management sequencing priority.
We've got a packed roadmap for this one. We'll be looking at epilepsy rules, Category G89 sequencing, neoplasm and post-op pain exceptions, laterality clinical defaults, and finally, those tricky etiology and manifestation conventions. Let's jump right in.
Kicking things off with Section 1, Epilepsy and Recurrent Seizures, and specifically Category G40 versus R56.9.
Listen, if you take away one thing from this section, make it this. Never, ever use Category G40 for a single isolated convulsion. It happens all the time, but a first-time isolated seizure actually maps to R56.9. Category G40 is strictly reserved for recurrent epilepsy. Now, when you do assign G40, you've got to decode those 5th and 6th character modifiers based entirely on the provider's documentation. You need to know if it's intractable, meaning it's refractory or poorly controlled by meds, versus non-intractable. And you have to capture whether the condition is with or without status epilepticus. It's like a puzzle you have to get exactly right to show the true severity.
Moving right along to Section 2, Category G89 sequencing rules. We're talking about exactly when pain needs to lead your claim.
This right here illustrates the absolute golden rule of G89 sequencing. If your patient is admitted to a pain clinic strictly for pain management, say they are getting a pain pump placed, a nerve block, or an epidural injection, G89 leads the claim as the principal diagnosis. It's the whole reason they are there. Conversely, if they're admitted for a surgical procedure to treat the underlying condition itself, like a spinal fusion for arthritis or trauma, G89 drops down to a secondary diagnosis, just to specify if that pain is acute or chronic.
So when the encounter is explicitly for pain control, you're going to step through your coding like this. Step 1, you always assign G89 first. Step 2, you follow it immediately with the specific underlying cause, assuming it's known. For example, if a patient comes in for pain management of acute neck pain due to a recent trauma, your first step is sequencing G89.11 for acute pain due to trauma. Then, you follow that with code M54.2, cervical GIA, to identify the exact site of the pain. Makes sense, right?
Now, you've got to pay close attention to how we distinguish general chronic pain from actual documented pain syndromes. Subcategory G89.2 is for general chronic pain. And get this, there's actually no officially defined time frame in the guidelines for when pain magically becomes chronic. You have to rely entirely on the provider explicitly documenting the word chronic. But look at G89.0, central pain syndrome, and G89.4, chronic pain syndrome. These are entirely different clinical beasts compared to general chronic pain. You can never just assume a syndrome because a patient has been hurting for a long time. You absolutely need specific provider documentation to use those syndrome codes.
All right, Section 3, neoplasm and postoperative pain. These are the big exceptions to the rules we just talked about.
Here is the crucial takeaway for cancer-related pain. G89.3 is your absolute go-to code whenever pain is directly caused by a primary or secondary tumor or even the tumor treatment itself. What makes this code an exception? Unlike the rest of Category G89, this code is assigned regardless of whether the pain is acute or chronic. The sheer fact that the pain is neoplasm-related takes complete precedence over the duration of the symptom.
When you're treating that neoplasm-related pain, specifically for pain control, just follow these 2 steps. And here's a pro tip. You do not need an additional site-specific pain code here. You simply sequence G89.3 as the principal diagnosis, and then you sequence the underlying active neoplasm code right behind it. That G89.3 code tells the entire story of the symptom.
Okay, let's talk postoperative pain, because this is a massive compliance trap. Rule 1, the default for unspecified post-op pain is always acute. Rule 2, and this is critical, do not code routine expected pain immediately following a surgery. It's a completely normal, integral part of the healing process. You only report post-op pain if it's out of the ordinary or complicating the recovery.
And Rule 3, if the pain is associated with a specific complication, like incredibly painful wire sutures left in a surgical site, you actually have to sequence the Chapter 19 injury or complication code first, followed by your G89 code to flag the pain.
That brings us to Section 4, Dominant versus Non-Dominant Clinical Defaults.
Picture this. You're reviewing a chart for a patient with hemiparesis. The record clearly states the weakness is on the right side, but it completely fails to mention if the patient is right-handed or left-handed. So what do you do if the medical record doesn't specify if the affected side is dominant? Honestly, this used to be a massive headache for coders trying to assign codes from categories G81 or G83 when the provider was ambiguous.
Thankfully, CMS gives us these hard and fast clinical defaults so you can confidently assign the correct laterality even when hand dominance isn't documented. It's super simple. If the patient is documented as ambidextrous, default to dominant. If the left side is affected, default to non-dominant. And if the right side is affected, default to dominant. Memorize these defaults for sure. They will literally save you from bugging your providers with unnecessary, time-wasting queries.
And finally, Section 5, Etiology and Manifestation Coding, looking closely at those code-first conventions.
The etiology and manifestation convention is a fundamental, non-negotiable rule. It requires the underlying condition, the etiology, to be sequenced first, followed by the secondary condition it causes, the manifestation. In your tabular list, you're going to see a Use Additional Code note under the etiology code and a Code First note under the manifestation code. Manifestation codes often literally say things like "in diseases classified elsewhere." That phrasing is a giant red flag telling you this code can never legally sit in your principal diagnosis spot.
Let's see this in action, and we're going to use a classic example, Parkinson's. First off, you must clearly differentiate primary Parkinson's disease, which is category G20, from secondary Parkinsonism, category G21, which is usually drug-induced or vascular. So, if your patient has primary Parkinson's disease, G20, that has progressed and resulted in dementia, you follow the indexed instructions directly. Step 1, you code the primary Parkinson's disease first with G20. Step 2, follow that with the resulting dementia, code F02.80, to capture the complete clinical picture.
Now, flip that around. Sometimes, Chapter 6 hands you a combination code on a silver platter, like G00.1 for pneumococcal meningitis, that wraps the etiology and manifestation into a single, highly specific alphanumeric package. The official guidelines strictly mandate this. Assign only the combination code when that code fully identifies the diagnostic conditions involved. When a combo code is provided that clearly covers all the bases, you do not use multiple codes to say the same thing. The system has already done the heavy lifting for you, so take the win.
Well, that wraps up this explainer. Thank you so much for joining me for part 73 of Decode Healthcare with Harshal. Make sure you hit that like button and subscribe, because you won't want to miss part 74, where we're going to decode chapters 7 and 8, diving deep into the eye and ear coding guidelines, including glaucoma staging, cataracts, and hearing loss rules. Until next time, take this final thought with you as you tackle Chapter 6. When you open up a chart, ask yourself, are you coding the chronic disease, the daily symptom, or the exact medical reason for today's encounter? Master that sequencing distinction, and your claims are going to be absolutely bulletproof.